Thank you very much for the invitation to speak today. And first of all, apologies. Somewhere between Melbourne and Gothenburg, my voice went missing. So please bear with me as I try and make sure you can hear me throughout this. And if you can't, please wave. Can I just get a sense, first of all, of the interests of the people in the room? Because this topic is really one that affects many people in many areas. I'm not going to ask you any questions at all. I just want to get a sense of numbers. The number of people in the room who work in diagnostic laboratories or pathology? Yeah, quite a few. And people that work predominantly in clinical services, clinical delivery? Probably, yep, a bit more again. And in policy areas, decision making? Great, good to see here as well. Okay, is there anybody, any area that, I'm not going to ask you, but there are people in the room who I haven't covered that don't fit into any of those at all? Oh, so maybe, that's it. Laboratory scientists, hands up. Yeah, and patient advocacy support groups at all? No, okay, I think that covered most all of this. Still, I can see a row of interesting people. I'll have to find out afterwards what they do and what I've forgotten to mention. I talk up, I'll just get this. Okay, is it possible to put the talk up for me? There we go. So I don't have any conflicts of interest to declare. So this session is very timely, I think, as around the world there are more initiatives and more countries grappling with working positively towards ensuring that genomic medicine and precision medicine are part of the healthcare system. And this is really a considerable task, as this quote from a paper by Zonitza Stark and Catherine North with many international authors identifies. The scale of the implementation challenge is formidable. And it's important to have a global learning health system. And of course, each health system itself needs to be one that supports learning and change as well. And the transition that we're talking about, of course, is one from genomics as predominantly a research tool being used to answer questions about biology and understanding the human genome, where the genomics and bioinformatics particularly, you might be familiar with this analogy, needs to be faster, more novel, innovative, groundbreaking, through to clinical practice, where genomics needs to be delivered in a way that's rigorous and reliable, where, like an airline, you know how many people are going to be on the plane, how much it's going to cost, when it's going to depart, when it's going to arrive. And I would add to this slide somewhat that the next challenge is then the scale up of that. That at the moment, what I'm going to describe is that middle picture where we're providing genomic tests as part of clinical practice, but it's not yet integrated in clinical care, where clinicians are providing the testing but funded through a research program to look at the impact of that testing to provide evidence for then how that can be implemented into this health system at scale. And to do that, really a whole of system change is needed. It's not sufficient to just work in diagnostic laboratories at getting the testing happening, or just in information IT, or just in the clinical realm. It needs lots of people working together to create, to change, and to create change. And underpinning all of that, of course, is the people with medical conditions and ensuring that this works in clinical practice and provides benefit to them and the health system. So I'm going to talk about how we're doing this in Australia, and in particularly in the state of Victoria, the Melbourne Genomics Health Alliance. So Australia's health system is complex. I think probably everybody says that about their health system. In ours, each state has their own health system for hospital care, public hospital care delivery, and genetic services sit within those state-based health systems. But in addition, there is federal government funding and a federal government health system. And so as a result, we have a highly complex set of arrangements for funding across states and national work, which is why It's important that there's also Australian Genomics Health Alliance, which took our Melbourne Genomics model and works across the states to harmonise approaches with research funding. Melbourne Genomics started in 2013. It's a collaboration, it's not an organisation, but a collaboration between hospitals, research organisations and academic organisations, supported by the Victorian State Government. And it really was formed to reflect that recognition that multidisciplinary and multi-organisation collaboration is needed to get genomics and genomic medicine into care. Now, when we started, there was a lot of scepticism. It was initially instituted by the member organisations and then received government funding. When we started back in 2013, 2014, there was a lot of scepticism that anything could change the health system. So I want to say at the beginning, what I'm going to talk about is actually what has created change, an approach that's been successful at creating change. Oh, sorry, So we've had impact, our results have had impact on federal government policy and funding, on state government, our state government funding. The programs that we've had have been, some of those have been rolled out nationally, and also the members have been able to leverage the work to gain philanthropic funding. I think from the sort of $39 million, there's been more than $70 million of additional investment secured. And just because it's nice to say, we've also won awards. One of the award winners, this is when it's sitting in the front here. So I'm going to talk about our approach, and this is really very much a skim over the program as a whole, and I welcome lots of questions on details of this. And then I'm going to go into some more specific examples, but still at a fairly high level, and I think Bill's talk after mine will go into much more detail in his area that will be, I think, very complementary to what the high level that I'm talking at. So at the core of our program are what we call flagships. These are clinical projects, effectively 16 clinical projects that run over 2 years or slightly longer, which are doing a head-to-head comparison of testing in the real world. So not on research cohorts, but on patients that are coming into clinical care prospectively, so they haven't generally had genetic sequencing or a lot of testing beforehand. So this reflects the real world of genomic medicine in the future. And these 16 conditions are deliberately very diverse. We want to understand what is common between different disciplines and different clinical indications, and what needs to be more specific or tailored to particular areas. So as well as spanning germline genetic conditions, we also have a flagship around microbial disease that I'll talk about later on, and also a couple of flagships in somatic cancer. Excuse me. The design that we've adopted is called a hybrid effectiveness implementation design. That is, rather than just looking to see, well, what's the diagnostic rate? What is the impact from arising from genomics? We also, and the impact on care, we also look at how is this done, what improvements to make, how can this work? So patients receive, generally, there are some exceptions, but generally singleton whole exome sequencing in parallel with usual care. At the time, we chose whole exome sequencing because it was clinic ready, and these tests are conducted by clinical laboratories, not by research laboratories, as an accredited test where that's available. So patients get the test results, and we do an evaluation of the impact comparing, because they're receiving usual care in parallel, we compare directly the impact of usual care and the impact of the diagnostic test, and then look to see what decisions clinicians make on the basis of those test results. And the outcome that is evidence for the use or not for using this. At the same time, the workforce is gaining experience, and they're iteratively improving processes to make them work, so process evaluation. So we get then design for what an acceptable, feasible system is. And through that, and I'll talk more about this, there's that process also, the clinicians driving this and leading it, that really fosters clinical change and appropriate adoption, and that's the third part of my talk today. So what's really critical and what takes the flagships, we've ran competitive processes for the flagships to determine which flagships would run. And one of the challenges, I think, for the clinicians involved in that has been that this is very much designed around evaluation to guide policy and practice. It's different to a research project, a usual research project where you're looking to answer a novel question. Here we're looking to take what's already known from research and test it out in clinical practice. And so the aim is for clinicians to say, well, this is how we think clinical practice would work on the basis of research evidence. These are the patients we think are worth testing, rather than let's look as many as possible and see what the diagnostic rate is. It's really honing on this is what we think would work in clinical practice and then finding out whether it does or not. So it's very clinically focused and driven, as I said, around policy, because the outcome here is to change, we're looking for is to change government policy and particularly funding policy. And particularly funding. And so it's identifying which patients are worth testing. So the right patient, the right test at the right time. And we do a range of analyses, which I'm not going to have time to go into, but we've done quite a bit of different health economic analyses, and that's one of the big challenges in this area. And then, as I said earlier, the other part of this is the right way, what's acceptable, equitable and effective. And we have a big focus there on participant views and involvement, and unfortunately I won't have time to go through that today, but I'd welcome questions on it. So our main research study, the main outputs would largely be research papers, and while we have plenty of research papers, actually our main focus and our main output is on evidence reports. We've developed, going back, we've developed a format with the Victorian State Government of synthesising the results down into a format that is the way what the government want to see and understand. And it's challenging doing this to get it so simplified down while still what we have, the nuance, still has the nuance. But it's very much about making recommendations to them of what is worth doing and equally where more work might be required. So this approach has had impact across all levels, I would say, of change, and I'm going to just give some examples of those. The first and most striking one, I would say, has been on our federal government and also state government. This was one of the first flagships that we ran, childhood syndromes. Zonitza Stark and Sue White were the key people involved in this. There's been a number of publications which you may have seen. This was evaluating the impact of whole exome sequencing with analysis targeted to the genes likely to cause the, based on the clinician's diagnosis of 80 children with likely Mendelian conditions. So that would be better. These are not the cases of the difficult to diagnose. These are the cases where I'm possibly Sonia is going to cringe when I say this, but the easier to diagnose, the ones where the clinician has a high level of suspicion or has made a clinical diagnosis and there are many genes involved. And the results were striking, with more than 5 times the diagnostic yield, which was, I think, much higher than we had expected. And also impressively, there was a 30% of those diagnosed had a change in management, which was a lot higher also than anybody had expected at the time. And the figures there, the cost by diagnosis reflects current costs, but at the time it was a 1/4 of the cost for testing compared to usual care. And being a lot of genetics people in the room, it won't surprise you that there was also those families that received a diagnosis, in the next 18 months there was many more pregnancies than those where there was no diagnosis. That had an immediate impact on the Victorian State Government, who funded genetics services to provide exome testing to families, 8.3 million, not enough, but a great start. And then federally, so this is an example of how the state and the federal, the state and National Australian Genomics work together. Australian Genomics put an application into government for national funding of exome sequencing. It's the Medical Services Advisory Committee, and that was completely based on the data from the Melbourne Genomics flagships. That was just late last year, that was approved. So the recommendation has gone to government that exome sequencing should be funded. Let me correct that, exome analysis should be funded. So it's very much forward-looking. It might be done by genome sequencing, it might be done by exome sequencing, but that analysis should be funded irrespective of the technology. And there should also be funding for reanalysis for those that are undiagnosed. The next flagship with some similar people in was more complex. I'm really not doing well with my moving on here. So this was looking at the impact of exomes in the sickest, most complex children, multiple specialists involving high medical acuity, severe functional impairment. And this one's been slightly different in that it was a comparison to a matched cohort from before genomic sequencing was really being used through flagships or in clinical practice at all. And that has also shown it's like it's got a mind of its own. I'm not even touching anything. There we go. That's also shown a increase in diagnostic rate. Importantly, a reduction in invasive tests, 1/4 of the invasive tests in the matched cohort. 1/3 of the patients across the cohort had a change in care. And the cost effectiveness of the standard testing was 1/3 the cost per diagnosis of the matched cohort. So it's really affirming what we've seen and extending what we've seen in the within cohort group. Within this, there was a subgroup where rapid exome sequencing was done, and that showed cost savings of more than 500,000. That work's been published, and just to acknowledge Alison Jung, whose data this is, Sue White, Tiong Zonetsa, and the Complex Care Flagship, who did this work. And that work, that rapid exome work, was then rolled out nationally through Australian Genomics as a research project, implementation research project. The results from that have been incredibly impressive, and I would encourage you to go to Zonetsa's talk, which is C01.1 in this conference. So our main target was government, but not only government. We're also looking to change practice across the hospitals as well. And I think one of the maybe surprising and rapid changes that we've seen has been change in infection control practices. What we call superbugs flagship is looking for antimicrobial resistant organisms identified during screening practices. So this is not the cases that have clinical presentations as such, but where somebody's colonised and there's not yet a clinical presentation, or their environmental screening as well. So whole genome sequencing of the microbe was added into those screening practices when a resistant organism was detected. And then they looked at rates of transmission within hospitals and across hospitals. That showed up to 34% transmission rate across 8 hospitals, within hospitals of up to 34% of isolates. And interestingly, one network had 4 times higher rate of transmission for VAN-ARE, which is an environmental organism. Those results sort of alerted that hospital and the hospital network to that they were really an outlier, and the hospital executive were very engaged, and they changed their cleaning practices to be in line with the others across their entire network for very large hospitals and a lot of smaller sites. Now, while some of the flagships have a sort of slightly competitive, our diagnostic rate is higher than your diagnostic rate kind of view, from our point of view, there is no such thing as a failed flagship. The point here is to work out right test, right time. That might not be exome sequencing, or it may be other factors that come into play than the diagnostic rate in making decisions. So we had dilated cardiomyopathy work flagship, which did not have really brilliant detection rates, but actually what was shown was what was detected through whole exome sequencing, all of those could be detected through a comprehensive cardiac panel. So the recommendation really was that there should not be any change in practice above the cardiac genetic panel What we uncovered, though, was I think everybody had assumed that there was standard practice across these hospitals in provision of any form of genetic testing, let alone genomics, and that turned out not to be the case, with half the sites actually not providing a comprehensive cardiac panel. So those two sites, so while the Flagship has found that on diagnostic rate, cardiac panel is sufficient, actually those two hospitals that weren't providing a cardiac panel have now introduced that into their clinical care. Oops. So I mentioned earlier we do process evaluations and looking at what's changing the Flagships, and we're busy collecting that. We're in the final year of our program at the moment. We're busy collecting that across all the Flagships at the moment. One of the things I think that we've learned, and I think if we'd been able to, would have included much earlier in the program, is implementation science. So this is the research to look at what works in implementation and what doesn't work in implementation. So we can look at changes in processes. The implementation science is the methodology to look at what helps create those changes and what might present barriers to change. It's a complex area. We've got really great collaborations with the Australian Institute of Healthcare Innovation at Macquarie University. And if people are interested in this area, then I'd really encourage using maybe this paper as a starting point. It gives a review of different types of implementation theories, models, frameworks, the differences between them and their strengths and weaknesses. And I think what the challenge that we're grappling with now, I've talked about changes that have happened within hospitals, but largely they've been within particular parts of the hospital. And what we're finding now is the hospitals are grappling with how they do this, how they create change to incorporate genomic medicine at a hospital-wide way. Hospitals in Victoria and Australia have clinical governance frameworks about ensuring quality and stage introduction of change. Quality introduction of change. In Victoria, they have frameworks for new technology, but they're telling us they don't work for genomics, and we're working now to understand why they don't work and how we can maybe create a framework for clinical governance, the introduction of genomic medicine at that hospital-wide level that will support change in the future. So it's just probably gathering from this, what we're doing is enabling change to happen, but the agents for change are the health services, the health system, and of course the clinicians themselves. So the health economic data that we've gathered, really the testing is cost effective when genomic sequencing replaces other investigations. That requires clinicians to change their behaviours, to stop ordering tests and investigations that they are used to using and replacing them with genomics, and that itself is quite a large task as well. And the model we've used for this is called the combi model. This is a model of behaviour change that's applied very widely, including in health and health professionals. And this model says that behaviour is influenced by an individual's capability, their opportunity and their motivation. And equally, behaviours influence capability, opportunity and motivation. And so in our program, the opportunity we've provided is through funding of genomic sequencing, and of course, in integration into the health system, it's very much about having funding there as for clinical testing. The Flagships have assisted with motivation and providing evidence of when this is worth doing. In the experiences that people are getting from their colleagues, maybe those that aren't involved in the Flagships are becoming more motivated, we've been seeing, by seeing the impact on patients that their colleagues are managing. And I'm now going to present the work we've been doing around capability, and this starts to get up to the scale up part. How do we scale up beyond Flagships as well? So this is very clumsily put, but we've put strategies. We've had a series of strategies to help build clinician capability to make sure they've got sufficient genomic literacy skills and confidence. First of all, and this sort of fits with different stages of adoption. So at the beginning, you really need people that are able to be genomic champions, people that that will be the leaders within their discipline that their colleagues will go to say, how do I do this? What do I do? Or to get advice. And we've done that by funding flagship clinicians to work for 2 years, sort of more of 0.4 FTE, but also by funding 10 people to work full-time in genomics or half-time for 6 months or half-time 12 months to get hands-on experience before genomics might actually be hitting clinical practice, even that could be research experience. Through the flagships, it became really apparent that we needed to be providing continuing professional development for the people whose practice who could see that this was going to be hitting their practice soon. We've been running, just in the last 6 months, workshops for clinicians. We're just about to run our first blended learning course, which is oversubscribed. We've been running variant curation workshops for clinical interpretation, and we've established a Masters in Genomics and Health as well. So a variety of strategies, and what we're really trying to do is make sure these are sustainable beyond the life of the program. And then the next challenge, so that works for the people involved in the flagships or in our member organisations, but the next challenge is how do we take what's been learnt from the flagships and make sure that clinicians that are going to be impacted beyond our member organisations, so across Victoria, are prepared to implement genomics. We're now moving into this area of knowledge translation, so dynamic and iterative process, and starting to get to that multiple, not just the one jet, but the multiple jets. And our first test case for this, which we're just starting now, is using the solid tumour flagship. So this provided a large panel test to patients with advanced cancer to look for variants that for clinical management and trial entry. The results of that suggest that this is worth doing, and certainly oncologists around Victoria are aware that this is something that they need to be incorporating and aware of. And so we are testing out an approach guided by evidence of what works in knowledge translation, of a local champions in a region, and using the experience from the flagship to develop a clinician decision tree and rolling those out in one regional area in Victoria and then comparing that to other areas to see what difference it makes on access to information about genomic testing and clinician confidence regarding making genomic testing. So even though this testing isn't yet available, we're preparing the groundwork so that when the tests are funded, people are ready to go rather than having a mess of people not confident, underprepared. So as I've been saying continuously, our program is designed to enable change. I've talked about the clinical service design projects and workforce development. I'm just briefly going to touch on rapid adoption of innovation because this has been about a third of our program funding, or more. We've spent somewhere between $10 and $12 million. We've had 80 people working on information systems. Data, of course, is crucial, and particularly in a country and a state that has decentralised approach to healthcare. Having systems that are shared across organisations to manage the data and to store the data that's being generated from clinical tests and make that available to research is critical. We've established Genomic, which is now live in 2 organisations, being used in clinical care in 1 and the other's just waiting for their accreditation, and we're in the process, I think, of rolling out to a 3rd. This is cloud-based. For the techies in the room, it's serverless architecture, so really kind of cutting-edge, highly cost-effective. It provides a platform for analysis and also for interpretation, for variant curation and interpretation. It has a standards-based centre to it, so we can easily put other organisations onto this, and the rollouts have been going quite rapidly. And we can also incorporate new services, and we're currently working on what the research part of this will look like, how researchers can come in and use the data for research, and also on linking in clinical information, so we start to move away from just genomic information only to more precision medicine approach. There's been a huge amount of work in governance, as you can imagine, and that's sort of how do we manage data from multiple independent organisations, the responsibility and authority, and also with patients around their views on the use and management of this data. So I think we've calculated we've got more than 90 projects underway or now nearing completion across the current 4-year work program. The circles are the ones that I've touched on here. As you can see, there are many areas that need to be done. We have a very broad program with lots of projects underway along the line that because so many different changes are needed, and when you start, you don't know exactly what's going to work. This is very much a process of testing out approaches to see what works, and some succeed and some do not. And so just focusing on the picture on the left, I guess this is very much about testing out approaches to implementation. And I think what's missing from those cogs is planning, improving, evaluating, implementing, and we would put in there prototyping. So all of these we treat as proof of concept projects effectively. They're an opportunity to test out what works. And we think the success factors in this are having a 5-year vision, not starting with where you are now, but working out what genomic medicine will look like in the future, how it can be done, and working towards that rather than the next step. In being clinically focused, so not driven by research questions, but driven by what normally happens in clinical practice. We'd say there's paradigms, there's sort of precedents there in clinical practice for everything that we do. It's about finding those and using those as a starting point, being driven by what the clinician needs and what the patient needs rather than what is technically possible. Being policy directed, thinking about which changes you're trying to enable, who are the people that would make those changes and what do they need to know. Proof of concept first, as I said, providing the ability to make incremental changes while still providing a structure there so that it's not so random and undirected that nothing effective happens. I cannot stress enough, though I haven't talked about the structures we've put in place to support collaboration. That has been critical. I think everybody involved from the beginning, people often feel, well, I know what I need to do, but actually everybody has learned a huge amount by interacting and collaborating across organisations and also across disciplines. And it's been more challenging, definitely, much richer and much better outcomes because of that. And finally, evidence. We're not interested really in creating evidence. We would much rather, in a way, be taking evidence that other people are finding and testing that out in our environment. But that evidence isn't always there. And in particular, when it comes to implementation science and the health economics, that can be very much a health system-specific answer, that the evidence has to be created within your own system. So having an approach of always making sure that evidence is guiding decisions. So in conclusion, I would say that I think the barriers, talking to many people, I think the barriers that we all face in implementing precision medicine into our health systems are very, very similar. But the ways to overcome those barriers are, I think, somewhat health system specific. And what I've described is the approach that we've taken to overcoming those. And I think that that's an approach that's applicable more widely. Certainly it's been working for Australian genomics as well. But the specific answers of what works within that approach is going to vary between health systems. And so I think, that each health system has its own unique elements, and therefore what is going to be needed will be unique as well in the detail. And that's the sort of somewhat clumsy segue to Bill to be able to talk about the detail of what can happen within a project.
Thank you very much.